Okay. So today's class will be on valvular heart diseases. So before going to valvular heart diseases, the entire thing in cardiology begins with this something called as cardiac cycle. You should know about cardiac cycle because the entire cardiovascular examination, the heart sounds, knowing the basic hemodynamics, everything will be easy only if you understand the cardiac cycle. So I'll just be telling the important steps. Before that, I always tell this point while teaching. Heart is the organ which takes rest for most of the time in the body. So if you take the cardiac cycle, the average duration of one cardiac cycle is 0.8 seconds. Cardiac cycle is the duration, the events which take place between one systole to the other systole. And the total duration is 0.8 seconds. Of that, 0.3 second is systole, which is the contraction phase. 0.5 second is diastole, which is the relaxation phase. So more than 50% of the time, the heart is relaxing. So if anyone asks you which organ is taking rest for most of the time in the body, it is nothing but the heart. So 0.3 seconds for systole, it consists of 3 phases. 0.5 seconds for diastole, it consists of 5 phases. Systole and diastole, I mean ventricular systole and ventricular diastole. Like ventricle, the atria also has a systolic phase and diastolic phase, but the atrial systole is only 0.1 seconds. That 0.1 seconds comes in the last part of ventricular diastole. So just follow my pointer. Begin reading from the ventricular systole. So what happens at the end of diastole? We have the open mitral valve and tricuspid valve. I'll be telling only about the mitral valve in my throat discussion. So at the end of diastole, what happens? The ventricles are completely relaxed. The mitral valve is open. All the blood from the left atrium have been emptied into the left ventricle. This is the phase to start with. Now ventricular systole has to start. So now when the ventricle starts contracting, the pressure rises. This pressure closes the open mitral valve. This is the first event which is occurring. So you can very well see here, this point is the right atrium. This one is the right ventricle, left atrium, left ventricle. So at the beginning of systole, what happens? The mitral valve which was open, see the mitral valve which was open at the beginning of systole now starts to close. Now we have two valves which are closed. The mitral valve which is closed, the aortic valve both are closed. So the inflow tract of LV and the outflow tract of left ventricle both are closed. Now the left ventricle has to contract against two closed orifices. This phase is called as isovolumetric contraction phase, right? So once the contraction begins, once the pressure of the left ventricle goes beyond the aortic pressure, the aortic valve opens. Once the aortic valve opens, the blood from the left ventricle gets ejected into the aorta. It occurs in two phases. Initially, the ejection will be fast. It is called as rapid ejection phase. Then the ejection becomes slow. It is called as slow ejection phase. So these are three events which occur in systole. The phase of isovolumetric contraction, where mitral valve and aortic valve both are closed. The ventricle contracts against two closed orifices. Rapid ejection phase, which is manifested by opening of the aortic valve and pumping of the blood. A slow ejection phase is there, which is the third part. So the sequence of events which occur in systole are the open mitral valve closes. So closure of mitral valve begins systole. In between that, the opening of aortic valve happens, then ejection occurs. This is the sequence of events in systole. Opening of closure of mitral valve, opening of aortic valve, ejection. Why I am telling this point is closure of AV valves causes S1. So closure of mitral valve and closure of tricuspid valve at the beginning of systole causes S1. Immediately after closure, your aortic valve opens, which causes pulse. So S1 correlates with pulse. That is the only clinical point which you have to remember from this entire systolic part of the cardiac cycle. Now we'll continue the next story. What happens after ejection happens? Then the ventricle is completely emptied. It starts to relax. This is called as diastole. So ventricle starts relaxing when the aortic valve is open. This small phase is called as protodiastole. Then when the pressure falls even further, what happens? The aortic valve closes. That is what is given here. So the aortic valve which was open, the pulmonary valve which was open, now it has started to close. Again the same thing, like in systole, we are having a ventricular cavity with mitral valve which is closed, aortic valve which is closed. The ventricle is relaxing with two closed orifices. This is called as the phase of isovolumetric relaxation. So the first phase of diastole was protodiastole. Then the phase of isovolumetric relaxation. Again, when further relaxation happens, which is the low pressure chamber, the aorta, the left atrium. So left atrium opens, the mitral valve opens, blood from the left atrium goes into the left ventricle. This is just a passive process, right? The mitral valve opens, the blood which was already there in the left atrium is coming down into the left ventricle. This is called as rapid filling phase. Then when the rapid filling is over, we get a small pause. It is called as diastasis. The last part is very, very important, because what I told is the phase of atrial systole or the atrial contraction is lasts for only 0.1 seconds, and it occurs in the last part of ventricular diastole. So what happens in diastole, I told you, we have protodiastole, isovolumetric relaxation, then the rapid filling phase, then this phase of diastasis. After this, we have 0.1 seconds left. That 0.1 seconds, atrial contracts. Again, this opens the mitral valve and pushes the blood into the ventricle. So if you see any echocardiographic recording, you can see that the mitral valve and the tricuspid valve opens twice. The first opening is due to the rapid filling phase, which is nearly a passive process, whereas the second filling phase is the active process contributed by atrial contraction. Again, the sequence of events in diastole is very important, because during diastole, which valve closes? The open aortic valve closes. This closure causes one sound which is called as S2. So diastole begins with S2. What happens in between? The mitral valve opens. Normally, opening of a valve does not produce any sound, but if this produces sound, it is abnormal. After the first mitral valve opening, what happens? Blood from the left atrium comes into the left ventricle. This is called as the first filling phase or the rapid filling phase. This can produce a sound if it is abnormal. Then again, we have another filling phase, which is contributed by the contraction of the atrium. So the contraction of atrium normally does not produce a sound, but if it produces a sound, it is abnormal. I'll tell you what are the sounds later. So again, summarizing the whole cardiac cycle, S1 is due to closure of the mitral valve, which marks the beginning of systole. Then opening of aortic valve occurs, following by that ejection occurs. These are three important events in systole. What begins diastole? The closure of the aortic valve, which begins S2. Then we have opening of the mitral valve and left ventricular filling. This can produce a sound. Just remember, it is S3. Okay, this sound is called as S3. Then we have a phase of diastasis. Then again, the left ventricle fills by the contribution by the atria. This contraction of the atria pushing the blood into the ventricle can produce a sound. This phase is called as S4. So this is about all the things you have to know about the cardiac cycle. I took more time in this cardiac cycle because if you have to know auscultation, if you have to know cardiology, if you have to know valvular heart disease, this basic is very, very important. Now coming to our main topic as such. So 4 important valvular heart diseases are important for you: mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation. We'll discuss the important aspects slowly. The next one are the other 4 valvular diseases: tricuspid stenosis, tricuspid regurgitation, pulmonary stenosis, and pulmonary regurgitation. We'll finish in another 15 to 20 minutes. Okay. So before going to the mitral valve as such, know the structure of the mitral valve apparatus. It is not a single structure. Okay. So mitral valve is actually an apparatus. So you all know mitral valve is an aortic AV valve, atrioventricular valve, which has 2 cusps. So it is also called as bicuspid valve. The 2 cusps are actually anterior leaflet, posterior leaflet. So I think you can follow me. Right? We have anterior leaflet, posterior leaflet. So if you think in your 3D imagination, they have an anterior free wall which is moving. That is the one which can open and close. But the sides are not mobile. They are fused to each other. That is the anterior leaflet and the posterior leaflet are attached to each other by means of a connection. That connection is called as commissure. So we have 2 commissures: anteromedial commissure and posterolateral commissure. Okay, anteromedial commissure and posterolateral commissure. The leaflets and the commissure are attached to a ring-like structure which is called as the mitral valve annulus. Okay, leaflet are cusp. They are attached by the commissure. They are supported by the annulus. Now, for the valve to open, it has to be in synchrony with the ventricle, right? So ventricle contains a muscle called as papillary muscle. The left ventricle contains 2 main papillary muscle. One is the anterolateral papillary muscle and the posteromedial papillary muscle. Am I audible? Okay, we have anterolateral papillary muscle and the posteromedial papillary muscle. From the papillary muscle, caudate tendineae arises. This caudate tendineae goes and attaches to the valve leaflets. So now the ventricle contracts, the papillary muscle contracts, the caudate tendineae pulls, and the valve leaflets open. This is the entire mechanism of the mitral valve. So not only mitral valve, most of the valves have this the same structure only. So leaflet or cusp, they are connected by commissures, they are supported by annulus, they are moved by the caudate tendineae, which is attached to the papillary muscle of the ventricle. That's all you have to do. Okay, we'll start our topic as such. So we have only two types of valvular lesions are there. Either it could be a stenotic lesion or it could be regurgitant lesion. Stenosis means the valve size, rather than being in the normal size, it reduces in size so that the blood flow occurs in the normal direction, but it does not occur in the normal speed. That is what is stenosis. So mitral stenosis, the mitral valve reduces in size. The normal mitral valve size is 4 to 6 centimeters square. If it reduces, it is called as mitral stenosis. Again, a mild reduction will not cause any symptom. If it goes beyond a particular level only, we get a symptom. That level is called 2 centimeters square. If the mitral valve area becomes less than 2 centimeters square, we start getting symptoms. That is when we label it as mitral stenosis. So causes. For your exam sake of purpose, whenever you present a case of mitral stenosis, the one and only word which you have to mention is rheumatic heart disease. So the first, second, and third causes of mitral stenosis is rheumatic heart disease, and rheumatic heart disease. Some people, when they are presenting to me in the exam, they told rheumatic fever. So rheumatic fever is different from rheumatic heart disease. So I'll spend some time on that. Rheumatic fever is an infection which is caused by group A beta hemolytic streptococcus. So when the bacteria infects the body, it produces some antigens, which has a cross mimicry with the heart valves. So when the antibodies are getting produced, it attacks the bacteria as well as it attacks the heart valves. So it causes some acute valvular damage, acute heart damage in the form of pericarditis, myocarditis, and endocarditis. This is called as rheumatic fever. But once some infection occurs or inflammation occurs in the body, you all know, as in the 3rd chapter of your Robbins pathology, any chronic infection or chronic inflammation is going to lead to fibrosis and healing process. During the process of healing, what happens? More of fibrosis occurs, it is going to cause stenosis. More of fibrosis occurs, it is going to pull the caudate tendineae apart, it is going to cause regurgitation. So that's all about rheumatic fever. So rheumatic fever is an acute condition caused by molecular mimicry to a bacteria. Whereas rheumatic heart disease is nothing but the chronic fibrotic or inflammatory response to the infection. So rheumatic fever is different from rheumatic heart disease. Please remember that. A patient, if you have to label them as rheumatic heart disease, they should have got a history of rheumatic fever in the past. But that infection may not be very much obvious. It is said that 50% of the patients with rheumatic heart disease may not have a history of rheumatic fever in the childhood because it would have occurred as a small infection and it would have gone off. So please remember the difference between the terms rheumatic heart disease and rheumatic fever. Rheumatic fever is your pediatrics case. Rheumatic heart disease is a manifestation usually occurring in adults. It's your case. So in rheumatic heart disease, MS mitral valve is the commonest valve involved. Mitral stenosis is the commonest lesion. So 25%. So 25% of the patients have isolated mitral stenosis. But always remember, one lesion does not occur usually, because if there's a stenotic lesion, blood flow will not occur from left atrium to left ventricle, which is highly pathological, which is incompatible with life. So nature itself gives a if there is any net issues, please stop me and you can tell, because last time there are so many issues with the internet. I hope my net is fine here. So if there is any problem, you can very well tell me. So a stenotic lesion does not occur as such. It usually occurs in combination with the regurgitation lesion. So 40% of the patients have mitral stenosis and mitral regurgitation accompanied. Again, this is not the rule. Other valves may be involved. So aortic valve may be involved in 35%, tricuspid valve may be involved in 6%. So if at all you have to tell two valves which are commonly involved is mitral valve and aortic valve. Mitral valve is the commonest valve affected. Mitral stenosis is the commonest lesion. Aortic valve is the next commonest valve affected. AS and AR both can occur. So many of the time, many valves may be involved. It is called as multivalvular involvement. Remember two terms. If a patient is having both mitral stenosis and mitral regurgitation, it is called as mixed valvular lesion. So same two pathologies occurring in a same valve is called as a mixed valvular lesion. whereas two different valves involved is called as multivalvular involvement. So both multivalvular involvement and mixed valvular involvement occurs with rheumatic heart disease. There are three other differential diagnoses. I will compile it at the last. So regarding some more points, mitral stenosis for commonly females are affected. As I told you, the interval between rheumatic fever and the onset of rheumatic heart disease can range from minimum of 6 years to at least 20 to 30 years. In tropical countries like India, it occurs early. It occurs with average duration of 10 years. But in foreign literature, it is told that it occurs up to an interval of 20 years. The pathological hormone is called Upshaw bodies. I won't deal that, you can read it. So once rheumatic heart disease is over, the next differential diagnosis is called congenital MS. We have something called a Schoen complex. I'll tell it in another part. Lutembacher syndrome is nothing but congenital ASD with acquired mitral stenosis. It's also something like a congenital syndrome. We have a range of drugs which can cause mitral stenosis. I'll tell the drugs again later in some other part. Carcinoid is one tumor which can cause mitral stenosis. SLE can cause mitral stenosis. Hunter syndrome, Hurler syndrome, Fabry disease, Whipple disease. Post-radiation can cause mitral stenosis. Reasons are obvious. At least remember two: rheumatic heart disease, congenital MS, Lutembacher. The next two will be drugs, SLE, radiation. Okay. Don't get confused why I put the criteria for rheumatic fever here. It's just, as I told you, it's a comprehensive lecture. I'll be covering the majority part of heart disease. So just for completion sake, I have put here. Jones criteria is a criteria to diagnose rheumatic fever. Remember, it is not a criteria to diagnose rheumatic heart disease. So the 2015 modified Jones criteria, the first thing you have to tell is it classifies the people into two populations: low risk population and high risk population. Low risk population is the annual incidence of acute rheumatic fever is less than 2 per 1 lakh population, and rheumatic heart disease prevalence is less than 1 per 1000. This is called low risk. High risk is their rheumatic fever incidence is more than 2 per 1 lakh population, and rheumatic heart disease is more than 1 per 1000 population per year. We are in a high risk population. So just read the second part alone. There are 5 major criteria, right? There are 5 major criteria for Jones criteria. One is carditis. As I told you, it affects the heart: pericarditis, myocarditis, and endocarditis. 3 manifestations. Remember one thing: endocarditis is going to cause mitral regurgitation. Don't get confused. There can be pericarditis, myocarditis, endocarditis. We have arthritis. In India, in a high risk population, monoarthritis, polyarthritis, polyarthralgia. These 3 things come under major criteria. Because if you read some older textbooks, they would have been given only the term called as polyarthritis. But in India, always tell monoarthritis, polyarthritis, polyarthralgia. Hope you are aware of the terms. I'm not explaining that. So these 3 come under the major criteria. Apart from that, we have Sydenham scoria, erythema marginatum, subcutaneous nodules. These 5 are the major criteria. The minor criteria we have: prolonged PR interval, monoarthralgia. Okay, I'm dealing only the high risk population. Monoarthralgia, fever more than 38 degrees Celsius. So monoarthralgia and fever, these 2 are the clinical minor criteria. The ECG minor criteria is prolonged PR interval. The other lab will be elevated ESR more than 30 mm, elevated CRP more than 3 mm. So these are the clinical features. But I told you it is an infection caused by group A beta hemolytic streptococcus. So I need an evidence to prove that infection. So in that, we have something called as essential criteria. So either a past history of rheumatic fever is an essential criteria, or just 1 minute. Okay. So the essential criteria is past history of rheumatic fever and ASO titer, anti-streptolysin O antibody. So if the antibody is present, it's an essential criteria for rheumatic fever. So I mentioned about rheumatic fever only to tell you that rheumatic fever, once it occurs in a period of 6 to 20 years, patient can develop rheumatic heart disease. Okay, so I told you about mitral stenosis. Now, some other diseases can mimic mitral stenosis. It's not the causes of mitral stenosis. Some diseases mimic mitral stenosis. Some may ask you this question. Left atrial myxoma, it's a tumor in the left atrium. So it can compress the valve and it can cause a stenotic-like lesion. Thrombus in the left atrium, left atrial ball valve thrombus, and infected endocarditis. And infected endocarditis will produce a vegetation. It can cause a mimic of MS. Cor triatriatum is a congenital heart disease where there's a membrane in the left atrium. So myxoma, thrombus, vegetation, cor triatriatum membrane can are differential diagnosis for MS. Okay. So whenever I put the slide called pathogenesis, start imagining the 3D diagram which I showed you initially. So what happens in mitral stenosis? The mitral valve. Another point is rheumatic heart disease. The characteristic anatomical finding what happens is commissural fusion. So I showed you about the commissure where the anterior leaflet and posterior leaflet meets. Commissural thickening and commissural fusion is the important pathology which occurs in rheumatic heart disease. So when the commissures get fused, the valve cannot open freely. The free end cannot open freely. So the blood from the left atrium cannot flow into the left ventricle during the rapid filling phase of diastole that easily. So it continues to flow for a longer time. In spite of that, some amount of blood continues to remain in the atrium. Now what happens? Now the atrium is under stress. So if normally only 20 ml of blood is retained at the end of early filling phase, now 40 or 50 ml of blood will be there at the end of early filling phase or at the end of diastasis. Now the atrium has to pump more to push this excess of blood into the ventricle during the second filling phase or during the atrial systole. So when the heart has to pump more, naturally it has to increase its pressure. So left atrial pressure increases. So there's a stenosis at the level of mitral valve. Blood has a difficulty in flowing from the left atrium to left ventricle. The flow will be difficult. So the left atrial pressure has to increase. That's called as elevated left atrial pressure. It will try to maintain, but till a point the heart can compensate. But beyond a particular point, what happens? Now the left atrial pressure starts increasing. You know very well the pulmonary vein is the one which drains into the mitral left atrium. So when the left atrial pressure increases, the pulmonary venous pressure increases. Pulmonary vein gets its tributary from the pulmonary capillary. So the pulmonary capillary pressure rises. Again, if you think of your basic anatomy, pulmonary capillary is like a basket weave appearance around the alveolus. So when the pulmonary capillary pressure starts rising, the fluid starts leaking into the interstitium of the lung and into the alveolus. This is going to cause some fluid accumulation within the lung, which we call it as a pulmonary edema. I haven't put it here. It is called as pulmonary edema. So when the fluid is there in the lung, gas exchange gets affected. It causes hypoxia. Chronic hypoxia, remember, it causes vasodilatation everywhere in the body, except in the lung, where it causes vasoconstriction. So the chronic hypoxia due to pulmonary edema causes constriction of the artery. This is called as reactive pulmonary arterial hypertension. When the reactive pulmonary arterial hypertension means pulmonary artery has constricted now. So when this reactive PAH acts for a presence for a long time, it causes obliterative pulmonary arterial hypertension. So till now what I told, the left atrial pressure has increased, pulmonary vein pressure has increased, the fluid has accumulated in the lung, it has caused hypoxia, it has caused pulmonary arterial constriction. When the pulmonary artery is constricted, blood cannot come from the left ventricle to the left side of the heart. So the right ventricle goes for a pressure change. Now the right ventricle has to pump more to push blood against the hypertrophied or the hypertensive pulmonary artery. So the right ventricle goes for hypertrophy. So in spite of hypertrophy, what happens? The blood cannot push more against a high resistance pulmonary artery now. Now the right ventricle starts failing. When the right ventricle starts failing, again the same thing. The blood pressure will go into the tricuspid valve through the right atrium. Now the right atrium starts enlarging. Right atrium drains its blood from superior vena cava and inferior vena cava. Superior vena cava, when it gets enlarged, the pressure will be transmitted to the internal jugular vein, which is seen as JVP. When the pressure gets transmitted to the inferior vena cava, the liver gets enlarged because liver drains into the inferior vena cava. So you get congestive hepatomegaly. When the pressure is transmitted to the lower limb, we get edema. So right heart failure, only three important signs are there: elevated JVP, congestive hepatomegaly, and pedal edema. The main three. Of course, any other edema can occur. Gastric mucosal edema can occur. Pleural effusion can occur. Anasarca can occur. So any edema can occur. Whereas left-sided heart disease, the only one manifestation is fluid is going to get accumulated within the lung, which is called as pulmonary edema. Now the symptoms I'll tell later. So this is the entire pathogenesis. Hope we are clear with this. Stenosis at the mitral valve level, elevated left atrial pressure, pulmonary venous hypertension, pulmonary capillary hypertension, fluid leak and pulmonary edema, chronic hypoxia, reactive pulmonary arterial hypertension, obliterative pulmonary arterial hypertension, right ventricular hypertrophy, right ventricular failure. whenever any chamber dilates in the heart, it's going to cause atrial fibrillation. The one arrhythmia which in your level which is important is atrial fibrillation. Okay. So if you are very clear with this pathogenesis, knowing the symptoms is very easy, because the first thing which just happens is blood is going, the pressure is getting transmitted from the left atrium to the pulmonary venous side. So you can get dyspnea. Blood is not flowing into from the left atrium into the left ventricle. So patient will feel fatigue because blood is not flowing into the peripheries. So easy fatigability and dyspnea are two common symptoms of mitral stenosis. Again, reduced exercise tolerance is the same. When the disease gets advanced, we get symptoms of right heart failure. The edema, congestive hepatomegaly, I told you. Hemoptysis can occur in mitral stenosis. The same reason. Pulmonary veins get dilated. There are 3 or 4 reasons of hemoptysis in mitral stenosis. I have mentioned only 3 here. The bronchial veins also can cause rupture. So it could be due to pulmonary venous hypertension. It could be due to pulmonary edema, which causes a frothy sputum. It could be due to rupture of bronchial veins. A pulmonary infarction is common with mitral stenosis. It could be one of the cause. Frequent infections are common when the blood is more there. It is called as winter bronchitis. It could be a cause of hemoptysis. Again, angina is not a common symptom. I told you dyspnea can occur, pulmonary edema can occur, but the other symptoms, angina is not common. Angina, when I mean, it's a problem with the coronary blood flow. It's not a problem with the valve of the heart. Angina is a symptom related to the blood flow. Either there's a reduced blood flow or there's an increased demand causing a relative reduced blood flow. If angina occurs in a patient with mitral stenosis, it could be due to right ventricular hypertrophy. So there's a demand supply mismatch when there's right ventricular hypertrophy. It could be one of the reason. Associated coronary artery disease is one of the reason. And I told you left atrium is very much enlarged now. Whenever a chamber is enlarged, it goes for accumulation of blood and thrombosis. That thrombus, if it breaks and blocks the coronary, it can cause angina. So palpitation, the reason will be atrial fibrillation and Ordner syndrome. The anatomical landmark close to the left atrium will be the esophagus. So esophagus gets compressed to cause Ordner syndrome, the syndrome of dysphagia and dyspnea. So dyspnea, fatigue is the common symptom. We can get hemoptysis, angina also. Okay, signs. We have something called as mitral phases. I told you most of the cases of mitral stenosis present with atrial fibrillation. So we have irregular pulse. The pulse volume will be usually normal. We have signs of left heart failure, which is pulmonary edema. The signs of right heart failure, which is elevated JVP, congestive hepatomegaly, and pedal edema. Now again, a basic point about JVP. JVP is the pressure wave which is transmitted from the right atrium to the internal jugular vein. A wave, if you remember, A wave is the wave which is caused due to contraction of the right atrium. I told you when the right atrium contracts in the last 0.1 seconds of the ventricular diastole. Here already the valve is stenosed. Now the atrium is contracting more to push the blood. So obviously that wave will be prominent. So A wave is prominent in JVP, but once atrial fibrillation occurs, the atria cannot contract properly, so A wave disappears. So prominent A wave is the feature of mitral stenosis, but when atrial fibrillation occurs, A wave disappears. Now tapping S1 is nothing but palpable S1. I told you S1 is a sound which is produced due to closure of the mitral valve. Here what happens, I told you mitral valve opens twice, right? It opens once during the early filling phase. During the phase of diastosis, it partially closes. And when the atrium contracts again, second time it opens. But here, because of stenosis, the blood flow is continuous. The valve cannot close properly. So the valve is open for most of the time. Remember this analogy, when you are closing a fully open door, it will produce a loud sound. So in mitral stenosis, the mitral valve does not close in diastasis. It remains open. So when the wide open valve closes, it produces a sound. That sound is called loud S1. So to produce loud S1, the valve has to be wide open. It has to be stenosed, and the valve has to be mobile. Only when the valve is mobile and not calcified, it can produce the sound. So if one characteristic finding in mitral stenosis is a loud S1 and a tapping S1. But to be loud, it has to be pliable. It should not be calcified. Okay. So in the absence of calcification, the loud S1 will be produced. Again, pulmonary hypertension will cause loud P2 or loud S2. Normally S3 should not occur, because what is S3? It is a sound produced when blood from the left atrium flows into the left ventricle during early filling phase. the blood is not filling at all into the left ventricle. So obviously you should not get S3 in pure mitral stenosis. S4 can occur. What is S4? It is a sound produced during the late filling phase of diastole when the atrium contracts and pushes blood into the ventricle. So S1 should be loud. P2 will be loud in the onset of pulmonary hypertension. S3 should be absent in mitral stenosis. S4 can occur. Now again, remember the sequence of events which occurs in diastole. The aortic valve closes first, then the mitral valve opens. Again, here mitral valve opening will be difficult because of the commissural fusion. So the mitral valve opening is going to produce a sound. That sound is called as opening snap. So S1, loud S1, opening snap. Both are important findings in pure MS. Both occur with the non-calcified valve. And you all know the most important murmur is mid-diastolic murmur. Why mid-diastolic murmur? Because mitral valve opens in mid-diastole. Murmur is a sound which is produced due to turbulence of blood flow, either due to normal flow through an abnormal valve or abnormal flow through a normal valve. So here the valve is stenosed, the blood is flowing, it produces a turbulence. That's the sound. Why we get in mid-diastole? Because flow from the left atrium to the left ventricle through a stenosed valve occurs only during mid-diastole after the opening of mitral valve. So that's all you have to understand. So the entire basic is your hemodynamics. If you are very, very thorough with the hemodynamics and the cardiac cycle, you can understand every pathology. The entire thing what you have to understand is we get loud S1, we get opening snap, and we get mid-diastolic. Okay, the remaining part is very, very easy. Once you have clinically diagnosed the patient who have mitral stenosis, you do a chest X-ray immediately. Chest X-ray. Okay. So I'll just tell what are the findings which I told you. The mitral valve is stenosed, the left atrium has to dilate to pump blood. So there will be left atrial dilatation. We have a feature in left atrial dilatation, which is called a straightening of left heart border, shadow within a shadow. And in the lateral view of X-ray, we have a posterior bulge of the left atrium. I'll explain it with the diagram. What happens after left atrial enlargement? Pulmonary venous hypertension. So pulmonary veins get enlarged. How to identify pulmonary venous enlargement in chest X-ray? Pulmonary vein occurs in the interstitium. So you'll get some reticular or interstitial shadows in X-ray. But what happens is, more of blood or more of fluid accumulates in the lower part of the lung. So blood accumulating in the lower part of the lung causes more of hypoxia. I told you hypoxia causes vasoconstriction, bronchial pulmonary vasoconstriction. So in the lower lobe of the lung, the veins go, the arteries go for a vasoconstriction. So even though there's an interstitial opacity which has to occur throughout the lung, the lower lobe of the lung is spared. We get only a interstitial shadowing in the upper part of the lung. This is called as the upturned mustache sign, or the cephalization of veins. Curly A and curly B lines are just the interstitial shadows. I'll show it to you in the diagram. So just follow my pointer. This is the diaphragm. The apex is formed by the left ventricle. So I'll trace this. So this is the left ventricle. If you trace the left ventricle above, so I'm tracing the left heart border. The left heart border is formed by left ventricle. If in a normal X-ray you have to see, there'll be a small curvature which occurs. Okay, the left ventricle will gradually curve inwards, and then it forms another bulge which is called as aortic knuckle. But if you see here, the left ventricle continues straight into the aortic knuckle. This is called a straightening of left heart border. The straightening of left heart border means that's a left atrial enlargement. This one is the right atrium. Normally, from the sternum to the right atrium, the distance should not be more than 2.5 centimeters. If this distance is more than 2.5 centimeters, right atrium is enlarged. So this patient is having left atrial enlargement due to straightening of left heart border. We cannot appreciate shadow and shadow here, but this is a right atrial enlargement due to the distance of right heart border from the sternum is more than 2.5 centimeters. Can you see the reticular opacities which is extending till the last part of the lung? Chest X-ray may be kept as a spotter for you. Normally what happens is, this is the pulmonary artery. The one which I'm highlighting is the pulmonary artery. From the pulmonary artery, we have upper segment and lower segment of pulmonary artery dividing. From that, we have many branches. The branches of pulmonary artery never cross this limit. The branches of pulmonary artery will not be visible beyond 2/3 of the two-thirds of the lung field. But here it is seen till the last. That if you observe, only the upper part of the vasculature is very much visible. In lower, it is not that prominent. So this is called as the upturned mustache sign, or the cephalization. So I told you the mechanism of cephalization. Lower part, there is a Reactive vasoconstriction. So the upper part is bad. So straightening of left heart border indicates left atrial enlargement. Cephalization indicates pulmonary venous hypertension. Right atrial enlargement means pulmonary artery has also gone for some changes. So that's a right ventricular enlargement also in this patient. So this is a typical MS. This will be definitely kept for you in the exam. So in ECG, what happens? Left atrium has to enlarge. What's the sign of left atrial enlargement? In P, remember the term P mitral and lead to, which is a broad notched P wave in lead to. I am not having the picture, but this is somewhat obvious. What I'm tracing is the P wave. We have a predominant negative P wave. Remember, the normal P wave in V1 will be biphasic. There will be a small positive wave followed by a small negative wave. Here, the positive wave is small, but the negative wave is large. The negative wave is the represents left atrial depolarization. So if the negative component is large, we mean it is left atrial enlargement. So ECG shows left atrial enlargement, X-ray shows left atrial enlargement, cephalization, and right atrial enlargement. Curly B line is, this line is the curly B line. Can you see a horizontal line which is extending from the heart till the last part? This is a curly B line, which is again typical of pulmonary venous hypertension. One term they may ask you, what is Morris index in ECG? It's also a sign of left atrial enlargement. I'm not going to tell that, you can see it. But I told you most of the time P wave will not be visible in ECG because atrial fibrillation invariably occurs. Even in the presence of atrial fibrillation, we can guess that there may be a left atrial enlargement. We have two types of atrial fibrillation: fine atrial fibrillation, coarse atrial fibrillation. If the F waves or fibrillatory waves are very much obvious, it is called as coarse atrial fibrillation. So presence of coarse atrial fibrillation means possibility of left atrial enlargement. Right ventricular hypertrophy may also be seen in the ECG. You can read that criteria later. Confusing now. So this is the typical X-ray and typical ECG mitral stenosis. So once X-ray and ECG is done, the next thing is you are going to do a echocardiography. You are going to measure the flow of the blood in the echocardiography, that is called as Doppler. So echocardiography and Doppler is the next one. Need not know the all technical details, but why we have to do echocardiography is you have to differentiate the lesion to be mild, moderate, or severe. I'll tell you the reason why we have to separate this. So one important thing is we can measure the valve area in echocardiography. I told you normal valve size of mitral valve is 4 to 6 centimeters square. If it reduces below 2, it is called mitral stenosis. So 1.5 to 2 centimeters square is called mild MS. 1 to 1.5 is moderate MS. Less than 1 centimeter square of valve area is severe mitral stenosis. Some textbooks say the word critical mitral stenosis, where the valve area is less than 0.7 centimeters square. There's some controversy in some textbooks, but if some examiner asks you, you can tell it is less than 0.7. Harrison says it is less than 1. Now, normally the blood, don't read the second one, read the third one. Normally blood flows from the left atrium to the left ventricle without any problem. Okay. But if there's a stenosis, there's some pressure gradient developing. Now the left atrium is at a higher pressure. It has to pump more to push the blood into the left ventricle. So normal pressure gradient across a normal valve will be 0 for any valve. But when there is some regurgitation or when there's a stenosis, the pressure gradient has to rise. So when the pressure gradient is between 0 to 10, it is mild mitral stenosis. Between 10 to 20, it is moderate mitral stenosis. More than 20, it is severe mitral stenosis. So valve area less than 1 centimeter square, pressure gradient more than 20 millimeters of mercury means we have a severe MS. What is the pressure after MS? The left atrium has to pump more to push the blood. So it takes a longer time for the pressure to reduce to normal value. That is called as pressure halving time. If it is more means it is severe MS. Just remember that one. So less than 150 millisecond mild, 150 to 220 milliseconds moderate, more than 220 milliseconds is severe. So echocardiography, the uses, first thing you can visualize the valve. We can visualize the commissural thickening, we can visualize the valve thickening, we can visualize valve calcification, we can look for any thrombus, we can visualize the valve. That's the first thing. Next is we can visualize the chambers. We can visualize the left atrium, we can visualize the left ventricle, how they are filling. So left atrial dilatation, left atrial thrombus, even left atrial myxoma can be diagnosed in echo. Then the next thing is we are going to measure. That measurement is called as Doppler. So in just a middle point, Wilkins score is a point which is used in mitral stenosis. We use 4 points: leaflet calcification, leaflet thickness, leaflet mobility, and caudal involvement. It is given a score from 0 to 4. I'll tell the use of that later. Okay. Definitely you will not understand this picture. Just follow my pointer. Can you see a mouth-like opening? This is the fish mouth opening. Okay, the one which I'm showing now is the anterior mitral leaflet. This one is the posterior mitral leaflet. Okay, normally this should not be this thick. Here the valve is thickened, the valve leaflet is thickened. So we have thickened valve, calcified valve. The anterior mitral leaflet and posterior mitral leaflet meet at this part, the one which I am highlighting now. This part is called as commissure. This commissure should be free, but if this commissure is fused, it is typical of rheumatic heart disease. So you can see here, there's some commissural fusion. I know you will definitely not understand this, but just understand that this is commissural fusion, leaflet thickening, and leaflet fibrosis. So this is a typical feature of mitral stenosis. Because of stenosis, the valve cannot open. This is called as fish mouth valve. Okay, this is the only echo picture which I showed you, just to give an introduce you to echo. Okay, so what are the other criteria to say severe MS? We have to know mild, moderate, and severe for some reason I told you. So I'll tell you what's the reason. But just remember, presence of pulmonary edema is severe MS. Presence of pulmonary arterial hypertension is severe MS. Two findings on auscultation indicate severity of any vascular lesion. One is the duration of the murmur and A2OS interval. If the duration of murmur is longer, it means obviously the pressure gradient lasts for a longer time. So the lesion is very severe. So duration of murmur indicates severity of lesion. Next is A2OS interval. A2 is the part of S2. It marks the beginning of diastole. So if the mitral valve opens immediately after diastole, it means that the left atrium is in such a high pressure so that it opens the mitral valve very early. So a short A2OS interval means the left atrium is at a higher pressure, which means we are having a severe mitral stenosis. So longer the duration of murmur, more the severity of MS. Shorter the duration of A2OS interval, more severe is the murmur. So these two findings on auscultation indicate the severity of MS. It is your clinical question. How will you tell this patient is having a severe MS? By the A2OS interval and duration of murmur. Normal A2OS interval ranges from 30 to 150 milliseconds. So practical aspect, we cannot diagnose A2OS interval audibly. But anyway, it's a question for you. But duration of murmur, very well you can appreciate. Longer the duration of murmur, more severe is the murmur. One small clinical point is they tell something called as pre-systolic accentuation. Even though the murmur is mid-diastolic, I told you the mitral valve opens twice. So atrial contraction occurs in the last part of diastole. So it pushes the remaining part of blood. That produces increase in intensity of murmur in the last part of diastole. It is called as pre-systolic accentuation. Okay, not to confuse, I'll go next. So what are the complications? I told you atrial fibrillation definitely occurs. So 17% occurs in 21 to 30 years. By 51 years, more than 50%, 80% of the cases present with AF. Next is systemic embolization. I told you when the left atrium is very much large, it goes for thrombosis. The thrombus can break and go into the cerebral circulation causing stroke. It can break and go into the renal artery causing renal artery stenosis. It can break and somehow it can reach the renal vein. It can go to the renal artery. It can go to the capillaries. It can go into the renal vein. This is called the renal vein thrombosis. It can embolize into the coronaries itself. So I told you one of the reason of angina in mitral stenosis is embolization into the coronaries. Unless this embolization occurs, MS will not cause angina. The next complication is infective endocarditis. Any large flow, any high velocity flow through any valve is going to damage the valve, which can cause an itis of infection. So atrial fibrillation, systemic embolization, infective endocarditis, and the next one will be heart failure. I explained the mechanism of heart failure already, right? Left heart failure causes pulmonary edema, right heart failure causes pedal edema, congestive hepatomegaly, elevated JVP. So these are the 4 complications which can occur with any congenital heart, any valvular heart disease. Knowing all this is important. So I went very slow because I wanted you to know the approach. So you have to know what is the lesion, what is the etiology of the lesion, a small basic suppose pathogenesis so that you can understand the symptoms and signs. Then investigation will be X-ray, ECG, echocardiography. Echocardiography is done to diagnose whether it is mild or moderate or it is severe. Then you have to know about the complications, because I always tell whenever you are presenting a case or when you are planning a management, the management consists of only 3 steps. Step 1 is find out what system is involved and treat the systemic symptoms. Second is what is the etiology, treat the etiology. Third is treat the complication. So system, obviously it's the cardiovascular system, it's the valve. That's our diagnosis. Now, what is the etiology? So if it's a rheumatic heart disease, it has a specific etiology. Just one more point to add. So since the valve, the first thing is what system is involved, the valve is involved. The treatment for that system is surgery, because we cannot manipulate valve by drugs. So the treatment for the valvular involvement is going to be surgery, nothing but surgery. Now, what's the treatment of etiology? It is medical. There's something in the medical treatment, I'll tell you later. Next is the treatment of complications. There are 4 complications. Atrial fibrillation. So you have to treat atrial fibrillation. We have to treat infected endocarditis. We have to treat systemic embolization. We have to treat heart failure. That's all. This is how you plan a management. This is how you write a therapy, even in your exam case sheet. So valve, the treatment of the valve is by valve surgery, which I'll explain in the next slide. Now, the next one is treatment of the cause. So rheumatic heart disease being the most common cause. Once rheumatic fever occurs, once rheumatic heart disease is diagnosed, we have to give rheumatic fever prophylaxis lifelong. So prevention of recurrent rheumatic fever is the first one. The common drug which we give is called penicillin V, 250 milligram twice daily, lifelong. Okay, 250 milligram penicillin V lifelong. Now coming to complications one by one. Heart failure is an important complication which I am not going to touch today. One part of heart failure management is giving diuretic to reduce preload. As long as blood is going to enter into the left atrium, it finds it difficult to move. There will be elevated pulmonary venous pressure. But if you're reducing the preload, if you're excreting the excess amount of fluid from your body, this complication cannot occur. So giving diuretics like loop diuretics like furosemide, mineralocorticoid receptor antagonist like spironolactone is one treatment. So this completes one aspect of heart failure. Now I told you atrial fibrillation invariably occurs. The treatment of atrial fibrillation occurs in 3 steps: rate control, rhythm control, and stroke prophylaxis. Rate control, remember 2 drugs: beta blockers, calcium channel blockers. Only 4 drugs are there for, only 4 antiarrhythmic drugs you have to remember: A, B, C, D. A for adenosine, B for beta blockers, C for calcium channel blockers, D for digoxin. A has no role in atrial fibrillation. Okay, so adenosine has no role in atrial fibrillation. Either I can give beta blocker or calcium channel blocker. The digoxin should be given in the presence of heart failure. I'm not going to tell the doses because if I tell you, definitely you'll get confused. So once you become CRRS, you can remember the dose, but never forget the drugs. A patient in MS coming with atrial fibrillation, beta blocker, calcium channel blocker is a drug. Digoxin is given in the presence of heart failure. Rhythm control, again, the same drugs can be used. Other drugs like amiodarone can be used. Stroke prophylaxis is very, very important. Left atrium dilates, it goes for thrombosis, it goes for embolization. So how we can prevent this coagulation? By giving anticoagulants. I have a separate slide for that. So I told you about treatment of heart failure by giving diuretics. Treatment of atrial fibrillation by giving rate control drugs, rhythm control drugs, and giving anticoagulants for stroke prophylaxis. The third complication is infective endocarditis. So I told you the valve is under severe stress. So the question comes whether you have to give prophylactic infective endocarditis treatment. So prophylaxis is not needed. If infective endocarditis occurs, we have to treat. Okay. So stroke prophylaxis, what I told you, you have to give anticoagulation. So there are few risk factors for which you have to give. A moderate to severe MS definitely is going to cause a dilated left atrium. So moderate to severe mitral stenosis, you have to give stroke prophylaxis. This is the reason why you have to grade the severity of any valvular lesion. Prior history of stroke, prior history of embolization, definitely you have to start stroke prophylaxis. If a thrombus is visualized in echo, we have to start stroke prophylaxis. If the left atrial size enlarges more than 55 millimeter, we have to start stroke prophylaxis. So moderate to severe MS, prior embolization, thrombus, left atrial size more than 55 millimeter. We have to give anticoagulation to maintain INR in the range of 2 to 3. This is another question for you. What are the anticoagulants? We have vitamin K antagonist, novel oral anticoagulants. So newer oral anticoagulants mainly is of 2 categories: factor 2 inhibitors and factor 10 inhibitors. Factor 2 is also called as thrombin, TR. So thrombin antagonist means TRAN. So any drug which ends in tran, dabigatran, is a factor thrombin antagonist. Factor 10 in Roman numerals is written as X. Okay, so X antagonist is SAN. So anything which ends as XAN is a factor 10 antagonist. Apixaban, rivaroxaban, edoxaban, etc. So if anyone asks you what, because it's a 5-mark question for you, anticoagulants. So anticoagulants, injectable anticoagulant is heparin, which is non-specific. Oral anticoagulant is vitamin K antagonist, which is warfarin and its derivatives. Novel anticoagulant drugs will be factor 2A inhibitors, which is all the trans dabigatran, and factor 10A antagonist, which is an apixaban, edoxaban, and rivaroxaban. Why to know all these things is patient in acute emergency, we give heparin. Because vitamin K antagonist cannot be started directly, so we give heparin for a particular time. After that particular time, we start warfarin. But warfarin again has some complications, like we have to monitor INR for giving warfarin. So for that came newer oral anticoagulants. For that we need not monitor INR. So that's how the sequence comes. Why I'm concentrating on this is, again, this is an area where you get confused. Never get confused. There are only 4 complications of heart disease: heart failure, infected endocarditis, atrial fibrillation, and systemic embolization. Systemic embolization treated or prophylacted by anticoagulation. Infected endocarditis, I'll tell you shortly now. There's no role for prophylaxis. We have something called as treatment. Heart failure and by giving diuretics, and atrial fibrillation by rate control and rhythm control. Okay, just a small brush up about infected endocarditis. How will you diagnose? By modified Duke's criteria. Remember Jones criteria for rheumatic fever. Remember Duke's criteria for infected endocarditis. Again, I'm putting this slide because it's a comprehensive class on cardiology. So the major criteria is blood culture positive for a typical organism, that is Staph aureus, Enterococcus, or Viridans streptococci. We have to send 3 blood cultures in 1 hour. Remember that we have to send 3 blood cultures from 3 sites in our body within 1 hour. If any 2 of this, I mean, the typical organism grows in these cultures, any of these cultures, it is positive. Echocardiogram showing valvular vegetation is a major criteria. New onset regurgitation is a criteria. So the minor criteria is predisposing cardiac lesion. So presence of MS, presence of a VSD, all these are minor criteria. Intravenous drug abuse is a minor criteria. Fever is a minor criteria. Embolic phenomenon, this is a question. Some phenomena like Roach spot, splinter hemorrhages, these are embolic phenomena. Immunological phenomena we have splenomegaly, oscillar nodes. These are immunological phenomena. So presence of embolic phenomenon, immunological phenomenon, that is the clinical features: elevated temperature, intravenous drug abuse, predisposing cardiac lesion, and a positive blood culture not meeting the above criteria. So we get an organism which is grown in culture, but it is not typical. Like Streptococcus gallolyticus is not grown, Viridans streptococci is not grown, but we are getting some other organism. It comes under minor criteria. We send 3 cultures, but only 1 culture is coming positive. It comes under minor criteria. So we said definitely infected endocarditis when 2 major criteria are satisfied, or 1 major plus 3 minor. Possible infected endocarditis when 1 major plus 1 minor, or 3 minor criteria alone. This is the 2019 antimicrobial stewardship program, Indian guidelines on treating infected endocarditis. So whenever in infected endocarditis, remember 2 terms. Infected endocarditis can occur in a normal valve or a native valve. It can occur in a prosthetic valve, the valve replaced. So native valve endocarditis is caused by Viridans group Streptococcus, Enterococcus, Streptococcus gallolyticus, and non-Viridans Streptococcus. So both Viridans group and non-Viridans Streptococcus, Enterococcus, Streptococcus gallolyticus can occur. Remember the drug of choice: ampicillin sulbactam or ampicillin plus ceftriaxone plus gentamicin. Remember the second one: ampicillin plus ceftriaxone plus gentamicin. It has to be given for 6 weeks. Suppose if you are having some risk factor, for example, the patient is having some skin, you know very well that Staphylococcus aureus is an organism which is normally present in the skin. So an intravenous drug abuser is getting endocarditis, or a patient has gone for some surgery, he's developing an endocarditis, rather than the typical organisms, Viridans group or non-Viridans Streptococcus or Streptococcus gallolyticus, we get the Staph aureus. Any treatment for Staph aureus will be methicillin, vancomycin, and linezolid. So we give vancomycin here. So again, PV is prosthetic valve endocarditis. The treatment will be both. The one we gave for native valve endocarditis, ceftriaxone plus gentamicin. Also, we can give vancomycin. Just know the drug names. Okay. So leave off the deviation. Coming back to the topic as such, I told you about the medical management of mitral stenosis. We have something called a surgical management of mitral stenosis. So surgeries are 4 things. 3 things mainly. One is balloon mitral valvotomy. Next is mitral commissurotomy or mitral valvotomy. Next is valve replacement. Balloon mitral valvotomy is we are going through the femoral vein, going to the right atrium, puncturing the interatrial septum, going into the left atrium, going into the mitral valve, and we are opening the valve. This is called as balloon mitral valvotomy. We have another extreme where we are not going invasively. We are opening the heart. We are visualizing the mitral valve. We are cutting the entire valve and we are putting a new valve. The new valve may be either a bioprosthetic valve taken from other animals, or it could be a mechanical valve. So mechanical valve or this is called as valve replacement. We have one procedure in between these two. We are opening, we are visualizing the valve, we are just cutting it by surgically. This is called a surgical valvotomy. The same surgical valvotomy can be done some non-invasively. It is called as closed mitral valvotomy or closed mitral commissurotomy. So 4 procedures are there: balloon mitral valvotomy, closed mitral commissurotomy, open mitral commissurotomy, and valve replacement. There are specific indications. For example, when do you do balloon mitral valvotomy? Obviously, this is the first preferred one because it is non-invasive. So balloon mitral valvotomy is done when the patient is having pure MS without MR. There is no left atrial thrombus. There is no vegetation. The valve is not calcified. The pure MS without MR, without calcification, without thrombosis, without vegetation, we give balloon mitral because only then the surgical procedure will be easy. So other indication is balloon mitral valvotomy is preferred in pregnancy. Women of childbearing age, we can prefer. Previous surgical commissurotomy which has failed, we can do balloon mitral valvotomy. So I told you about Wilkins score, the 4 components, right? The leaflet calcification, thickening, fibrosis, and caudal shortening. If all these are present, balloon mitral valvotomy will be difficult. That's why I told you we should not select that. Okay, so nothing more on your part. So balloon mitral valvotomy is the least one. It's the most preferred one, but there are specific indications. Suppose if these criteria are not satisfied, patients having an associated mitral regurgitation, is having a calcified valve, we have to do valve replacement. Then when will you do closed mitral commissurotomy or open mitral commissurotomy? There's something in between. We are having a moderate MR plus moderate MS plus a mild MR. We can consider that in between one. So this is about surgery. Again, what the basic thing is, when will you do a surgery for a valvular heart disease? The generalization is any symptomatic valvular heart disease patient, we have to do surgery. Any symptomatic patient. Any patient who is severe, we have to do surgery. So a severe mitral stenosis, we have to do surgery. A patient who is symptomatic, we have to do surgery. Right? So that's why we have to know the definite criteria for severe lesion for anyone. So severe MS, I told you, presence of pulmonary edema, presence of pulmonary hypertension, A2S interval, duration of murmur, and the valve area less than 1 centimeter square, pressure gradient more than 20. We have to know all these values only to understand that these are indications for surgery, and there are you should know what are the types of surgery available. Okay, so till now we have discussed about the basics about cardiac cycle, the basics about how the different sounds are produced, the mitral valve apparatus and any valvular apparatus, about rheumatic fever, about infective endocarditis, and the entire thing about mitral stenosis we have finished. I went very slow. I took 40 minutes on this alone because I wanted you to understand this closely. So any doubts you can ask me at this point, because I'm going to continue with the remaining now. So I'll just give 1 minute break for you. Any doubts you can ask. If no doubts, we'll continue with the remaining. So